الصباح الجميل. طبعا احنا مبسوطين بوجودكم معنا. Today inshallah we will start with our first session with the moderator Dr. Abdullah Al-Hayfani. Dr. Abdullah is an associate professor of clinical pharmacy at Al-Qura University and director of clinical pharmacy residency program at Sulaiman Faqih Hospital in Jeddah. He held a PharmD and he completed his residency training in the United States and earned his executive MPA and MBCS. Thank you very much. Dr. Hayfani, yours.
Bismillah Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like really to extend my deep gratitude and appreciation for Dr. Muhammad Zaid, the chief of the conference, and for all organizing committee, scientific committee, for the invitation and all the efforts. It's my first time in Hail, and inshallah it will not be the last. Please join me in welcoming my professors and teachers, the experts in the field of clinical pharmacy. Would like to welcome Dr. Majid Al-Juraisi to the panel discussion. He's a pediatric clinical pharmacy consultant and chairman of clinical trial management at Kmark. And he's a very well-known in the field of clinical pharmacy and one of the founders of clinical pharmacy in the kingdom. The next is Dr. Sandra Leal, our guest speaker from the United States. She's the former EPHA, American Pharmacists Association president, and a global leader in the pharmacy advocacy, innovation, and public health. And she will join us, inshallah, remotely from the US. Dr. Ibrahim Sales, a professor at King Saud University and consultant in ambulatory care and MTM. And he also will join us remotely. Dr. Umayma Arab, the head of clinical trials at Saudi FDA, triple board certified, mashallah, and clinical pharmacist. Please join us. Dr. Abu Bakr Umer, clinical pharmacist expert at NOPCO, with leadership roles spanning the pharmaceutical industry, academia, regulatory consultancy. And the last but not the least, Dr. Mubashir Al-Suwaini, a consultant in ambulatory care and residency director at King Saud University Medical Center, Medical City, known for her commitment to training and humanitarian pharmacy services. If you just bear with us for a few seconds till our guests that are going to join us online.
Dr. Sandra?
Yes, I can hear you.
You are online now.
Are we ready to go? Dr. Sandra, do you hear us? And Dr. Ibrahim?
Nice.
It's clear.
Okay. Thank you. Really, thank you so much, really, for joining us. It's honestly, I'm so pleased, really. Some of our colleagues, some of them, they assist me in a while. And I'm so honored, really, to moderate this session with these experts. Without any further ado, if you allow me to start with our expert in the panel, Dr. Majid Al-Juraisi, mashallah, tabarakallah, with over 30 years of experience. You've witnessed an evolution in clinical pharmacy in Saudi Arabia in general and in ambulatory care in particular. Can you share with us your insights on the biggest clinical gaps you've observed in ambulatory care practice and how research can close those gaps? If you allow me just to connect what we are going to talk today with yesterday. So yesterday we tackled Dr. Abdelaziz, Dr. Mishal, Dr. Ijaz, and the panel discussion tackled the challenges in terms of, if you remember, in terms of privileging, giving the privileging committees and giving pharmacists privilege for prescribing, for example. Also, we tackled the challenge in terms of reimbursement from the insurance. As we know, we are heading toward privatization. Today, we're going to tackle the topic of empowering ambulatory care field via research and innovation. So this is going to be the theme, inshallah, today at this session. So, Dr. Majid, you have the mic.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته جميعا. صباحكم الله بالخير. It's my pleasure to be here in this conference among colleagues and friends. I'd like to thank the organizing committee for the invitation. I see the efforts and the, mashallah, momentum of increasing and upgrading and upscaling the AMP care in the country, which was صراحة a dream for me personally, although I am not AMP care specialist, but it is really يعني from يعني a long time I see this gap in our practice and the absence of AMP care. It is a dream صراحة for me to see a conference like this with this, mashallah, يعني huge and distinguished gathering of colleagues and professionals. Hopefully, inshallah, it will be a start for having the AMP care. Just to share with you what I was talking about, and this is my belief. I think the future, I'm not exaggerating if I say the future of clinical pharmacy is in AMP care. معلش يعني other specialties بيزعلون لكن this is the reality. Why is that? Because it is supporting the vision 2030 with the prevention program of distributing the ambulatory care services in the centers في الكنتري. وبالتالي the presence of a clinical pharmacy specialty in this services is really a must, is important, and is going to lead definitely the AMP care in the kingdom. So this is a side issue from the question that Dr. Abdullah just asked me to elaborate on. Absolutely, طبعا part of building and increasing and improving the reputation of AMP care clinical pharmacy services in the country, part of it is availability of evidence. فwithout having evidence, ودائما لغة الأرقام هي يعني الأساس. Having evidence of what we do, what we are impacted on, what we can do and improve, I think it's a must. And providing evidence is going to be through doing research, not only available of evidence, but also tackling certain issues and problems in the practice or in the community. So is there a gap? In fact, it's a huge gap, definitely, and it's not blaming anyone. It's part of يعني the involvement of the AMP care clinical pharmacy services in the country. How can we fill this gap? How can we close the gap as much as we can? Is by يعني emphasizing on the importance of the research. A correction of the introduction, سمي الدكتور عبد الله يمكن CV قديمة, لكن when I moved from Kmark to Saudi NIH, I can see where the Saudi NIH can support the research grants in AMP care. There is a huge support, and يمكن you have seen the research priorities that we have launched recently. جزء كبير منها, واحد منها is in the public health one, and also in other disease areas where ambulatory care is a part of. So again, availability of research grants that is supported by Saudi NIH is there. So it is an invitation for anyone to submit a research grant request to get grants for the research. So going back to the question about the how can we fill this gap in AMP care is having a group of researchers and having a plan. What are the areas, research areas, top research areas that we need to close, in addition to building capacity in research. بمعنى, if we have AMP care in many hospitals, where is the research entity in the services? So having, again, a plan from the leaders of the specialty, drawing the roadmap of research. أعتقد this is something that comes as a first step to close this gap.
Thank you so much, Dr. Majid. And really, I totally agree with you that sometimes the evidence-based that generated from research could convince not only the decision maker, but also the legislators to put new rules, and modify the current, which we really discussed yesterday about giving ambulatory care pharmacists more privilege to conduct their role in the clinics more properly and more efficiently, and that what Dr. Abdulaziz elaborated yesterday. Okay, Dr. Ibrahim Sales, do you hear me?
I hear you.
Based on your dual role in academia and practice, what type of research, whether service evaluation, outcome-based, or observational, are most urgently needed to strengthen ambulatory care in Saudi Arabia and to utilize the Saudi NIH resources, which Dr. Majid just has talked about?
Bismillah wa salatu wa salam ala Rasulillah. First, I want to thank the organizing committee for allowing me the opportunity to participate in the conference. And sorry that I'm not able to attend physically. I miss the energy of being around the AMP care practitioners, because it's quite a different feeling when you're with family. What I want to talk about is research in general. And going back to your question, there have been some reports that have already been published that are available, and many of the AMP care practitioners have worked on a lot of these different reports, and they've mentioned especially those outcome type of studies focusing on healthcare outcomes that are lacking in general here in the kingdom. So that's what I would stress, that we need more focus on outcomes. We do have a lot of practitioners that are working, but the problem is that we're working individually. So we're working in one center, and this is effective on a smaller scale. But if we want to be able to convey to the legislators and to the world what we're doing and the impact that we're making, then we need to focus more on the outcome type of studies.
Okay, so based on your practice in one of the leading centers in AMP care in Saudi Arabia, King Saud University Hospital, so what practical innovations have you applied or seen succeed in local ambulatory care clinics? Here or back in the US, where you have you done your residency training?
So I actually thought about this, and every one of us knows how to use ChatGPT. Every one of us knows how to use the internet and to search for different types of studies and different type of innovations. So this is something that's easy. And when we deal with our students, a lot of times, some of them won't attend the lectures, and they'll actually say, we can go to the internet and get this information. So many of the times as educators, what we're doing is that we're shifting our focus. So we'll give them the basic information, but what we're really benefiting them from is our experience. So I want to approach this question from a different perspective. So definitely we know that, and one other point that I want to mention is just like Prof. Abdulaziz mentioned yesterday, sometimes if you are actually are in a practice and you want to open up, for example, a epilepsy clinic, and it's something that's not needed by that healthcare center, then it's not going to be as successful. In the same sense, if I don't tailor the advice or information for the specific population, then it's not going to be as benefit. So in my brainstorming, I came up with a few different means or different types of approach that not specifically talk about innovation, because like I said, you can look up on the internet, you can even ask ChatGPT, what is an innovative service that I can use? But sometimes I think that the basic foundation is lacking. And these are things that I've been here for 13 years and I've seen in my interaction with different individuals on many different levels. So the first thing that I want to say when we're thinking about any type of innovation and we're thinking about research and how to apply it, one thing that we have to focus on is setting the bar high, setting the bar high. Now, like Prof. Abdulaziz mentioned in his the beginning of his speech, that where the 2030 vision is going and where we want to be. In order to do that, we have to set the bar high. And I'll give you, and this is what I usually do when I teach my students, I give examples. There was a competition that I was participating in, and it was about holding your breath, taking a deep breath and then counting as high as you can with that one breath, right? So I was the eighth person. There were 10 people up there. And so the first one counted up to 20. The other one did up to 30. Then one person reached 53. So most of the times when we think about our goals, we think about, okay, they reached 53. I need to reach 54. Or at least I have to reach at least 53. When I was sitting there, I thought to myself, my goal is to reach 60. My goal is to reach 60. And so I went above and beyond and what my target was. So sometimes what happens is that we look at the different countries throughout the world and we say, oh, we need to be just like such and such country. We need to be just like this one. But in reality, that's not what they want us to do, and that's not what we should do. We need to aim higher than that. So our goal should be to be better than whatever country or whatever practice that's already available. Because what I've seen here is something that really is devastating and hinders that from us reaching those goals. And it's called something that they call inferiority complex. And I witnessed this throughout me being raised in the United States, that many minorities are afflicted with this inferiority complex. Inferiority complex basically means that you always feel lower. You always feel like you're inferior, that you're not going to ever be as good. And this is not the case. We've had many people that have studied and are very bright individuals and are doing hard work. But to actually overcome that, you have to set the bar higher. Secondly is identifying gaps in research. And not only that, we look at these different studies, but we need to figure out ways that we can improve that. And we need to add on and to lead the way. And one of the ways is to look at it as Saudi Arabia as a leader. Whenever I say, oh, if I meet people, I say, well, we're going to, whatever conversation is football or soccer, they said, they're probably going to win. They're going to be the champions. People look and say, no, how could that be? No, you have to focus and say, Saudi Arabia is a leader. Saudi Arabia is a leader, and come into that mindset. And that's the way to move forward. Third thing is respecting oneself and not focusing on status. And for example, a person could exercise and say, I'm going to, get buffed to impress my spouse or whatever the case may be. But in actuality, they should respect themselves. Respecting themselves means like they want to take care of themselves. And in the same way, we have to do this, where this is not about status. And when it was mentioned yesterday that it took decades for the United States to reach the level of ambulatory care, that means that it's not about status. It's not about me being seen. It's not me being on the front line. It's about us moving forward and progressing. So part of that is respecting yourself, because if you don't respect yourself, then no one's going to take you seriously and respect you. Next thing is to recognize your gold, I should say, because somebody is sitting on a mountain of gold, and they're using the gold for I don't know whatever case may be. Sorry, not moving enough. Okay. Yeah, if someone is sitting on a mountain of gold and they're using it for I don't know what, just trash or cleaning the dishes or whatever the case may be, you can imagine fill in the blank or whatever it is. If you have this mountain of gold and you're not using it effectively, then this is going to also be a problem and detrimental. Now, when I say this, that some things, and if I say this, everyone's going to say, "Oh, I know this," but in actuality, do we apply it? So we have a very valuable culture here, and if we act upon that, and if we learn and we go back and use that as our foundation, then these are the things that are going to help us to succeed. So when I talk about this, when we talk about, for example, an easy example anyone can relate with raising children. My mother-in-law said, you know, raising your children is actually a form of worship. You're actually getting good deeds for that. Not just like that. When I go to the clinic, I don't go and say, you know, this is a job I have to do. I have to work. I have to show, you know, my boss that I'm there and I'm working. No, I say this is me visiting the sick. I'm getting good deeds for that. Likewise, when you're working late, you're working hard hours, if you have the right intention, then you're getting a reward for that. And I think sometimes we forget this and we focus on how much money I'm going to make, what's my status, what are people going to think about me. And if we go back and we look at, okay, all right, you just said that we want to be better. We need to be better. You have to have something that's going to distinguish you to make you better. If you don't have something that's going to distinguish you, then you're going to be just like anyone else. But
Thank you so
we
much.
have something to distinguish ourselves.
Thank you so much. I'm really sorry, Doctor, for interrupting you, but really we have time restraints. I totally agree with you. Ethics, integrity, dedication. Without the former founders of clinical pharmacy, without the effort, even Dr. Abdulaziz yesterday, he mentioned that when he came back from the residency, when he got inspired by Dr. Sandra, he met Dr. Ghada and Dr. Might, and he worked with them to establish such. So really, as you mentioned, Dr. Ibrahim, integrity, dedication, ethics, this is very contagious, and this is what makes people trust you and work with you and empower you and the ambulatory care pharmacy as a whole. Let's move on to, if you allow me, to Dr. Sandra. Dr. Sandra, your work has redefined pharmacy role in public health and primary care. And we have seen how much you inspired ambulatory care pharmacy founder in Saudi Arabia, Dr. Abdulaziz. And honestly, the milestone that he and mashallah now his residents now they are crossing and leading ambulatory care field in Saudi Arabia. From your perspective, how can we replicate your model of innovation and pharmacist empowerment in countries like Saudi Arabia, the GCC?
Thank you for the opportunity to join you all today. You know, I've been working on my career now for 25, 30 years, really to try to advance the role of the pharmacist. And I currently work in regulatory affairs, and I've been working on advocacy and policy for recognizing pharmacist services. And so one thing I think about all the time, pharmacy can be practiced anywhere. It does not have to be in a pharmacy. It is the training that we receive as pharmacists that really make the difference with our point of view and the value that is unique in what we bring to the care of the patient and the healthcare system. We are moving away from talking about regulating pharmacy. We have asked for permission with collaborative practice agreements for a long time. We keep regulating every single condition that we're trying to manage, requiring more certifications, more CEs, which is time to do less of that. And what we need to move towards is what we are calling standard of care. And standard of care is the language other professionals are using. The medical profession has been using standards of care for a long time. That relates to the regulatory process, the legislative process, how they practice, and a standard for how they deliver care. For pharmacists, that is what we're doing in the United States. We are seeing very progressive states, and the one that I can call out as probably the leading state is Idaho, where they have removed regulations, and what they're calling standard of care now allows a pharmacist to train, to practice the way that they've been trained in an equal way to any other reasonable pharmacist, and also parallels what the medical profession is doing. This removes the regulation. This allows pharmacists to practice the way they've been trained, and we start removing some of those barriers that prevent us from doing what we need to do. And that is very exciting that we're doing that, because it's allowing more independent practice. It's allowing pharmacists to prescribe. It's allowing pharmacists to diagnose, if your training supports that, and if that's prudent and reasonable standard compared to other providers. So I encourage you to think about that language that we're moving to, more standard of care language versus over-regulating with what we've done historically. And I just want to echo some of what was said yesterday and today, and just the experience, even my own experience in practice. We've been showing and proving the impact pharmacists make for many years. That's not, there's not a lack of evidence for the impact pharmacists make. What we need is to actually incorporate pharmacists like other medical professionals in the system, and not try to prove ourselves over and over for what we know we can do. What we need now is recognition, implementation, and we need to convince others that what we're doing is the care that is required. And why? At least here in the United States, there are not enough providers to deliver the care that patients need. There are barriers to access, and so we must move to be able to make that point on a public health perspective and on a reach perspective that patients need to have this care. So it's an exciting time for pharmacy, because we're getting a lot more flexible in the ability to recognize pharmacists. So I just want to encourage that understanding of the standard of care model, and look at some of the examples that are very progressive, because I think we're moving in the positive direction to stop over-regulating pharmacy and allow us to practice the way that we've been trained.
Cassandra. Okay, let's switch gear, and Dr. Umayma Arab. As someone who bridged clinical and regulatory work from King Faisal Specialist Hospital now to the Saudi FDA, how can the regulatory environment in Saudi Arabia, based on what Dr. Sandra just has mentioned, based on her experience in the US, and you yourself, you get trained back in the US, how can the regulatory environment in Saudi Arabia better support pharmacist-led clinical research in ambulatory care settings and hopefully in the practice?
Thank you, Dr. Abdullah, for this question, because it's really important to know the differences between research in general and clinical trials, because in reality we see a lot. You can say half of our clinical trials are in ambulatory care with regard to cardiovascular diseases or endocrinology, oncology. Ambulatory care is there, but we need to know. I want to ask a question to the audience before I go there. By the show of hands, how many of you guys have conducted research only? I just want to see the difference between those who conducted clinical trial and research. Research, good. How about by the show of hands, clinical trials? MashaAllah. All right, I see few hands here and there for both, but we need to know the differences between both, because when you're in your institution, your hospital, you can conduct research and see the numbers and show your administration that you need to do more of this or more of that, and that's really good, because you're actually doing statistics and showing significance in what you're doing. But when I'm talking about clinical trials, and if we're talking about really very well done clinical trials, those investigators know their standards. I'm talking about ICH guidelines, the GCP guidelines in specific. These guidelines shows that there should be a team who is trained, who has the capabilities and the qualifications to do that. So a pharmacist in the team is important, and that I see all the time. We can say that there is a lot of pharmacists in these teams in clinical trials, but to lead it, it's a very important thing. I highly encourage not just clinical pharmacists, any pharmacist in the field who knows how to do investigational drugs or how to do forms that support the process in the background, and how to educate the patients, the participants, to be really part of the clinical trials, to make sure that they generate good data that can be generalized to the community, to the patients in public. Now, thinking also, if we're thinking in the future for pharmacist-led clinical trials, this requires a lot of training, honestly. It's not an easy thing to do, but I think we can do it. We have done so many things in our practice. Clinical pharmacists can do it, and I'm pretty sure it's just a matter of training and practicing with those who are experts in clinical trials. Research, I have no doubt that many pharmacists actually have done so much research that generated a lot of good data for supporting initiating clinical pharmacy. I want to say in transition of care, diabetes, anticoagulation. That's no doubt is there.
Thank you so much. Okay, I just I want you to elaborate more about the Saudi FDA play encouraging innovation without compromising patient safety, because I see what you're saying, that it requires a lot of training, definitely, but the pharmacist, remember that he or she is stationed as a proper individual, as a coordinator, linking between the physician, the prescribers, the testing, and most of these trials is being sponsored or by pharma companies. So without compromising the safety, how can the Saudi FDA push and encourage these clinical trials?
Again, really good question. And I think that maybe Dr. Majid can support me in this, because pharmacist is the link between healthcare providers and regulators in the field, because we know the policies, we know how to dispense medication, or we're basically the drug experts. So with that in the mindset, you can do it easily. Pharmacists in this area know how to take advantage of the good initiatives that are available there. We're talking about, for example, expedited versus a full review, or maybe knowing exactly what is needed in such opportunities. Maybe I'm thinking, today we want cell and gene therapy, tomorrow we need, I don't know, maybe biosimilars. So the pharmacists know exactly what is needed in the current situation. So these things, pharmacists can really help a lot. Now, incentives the SFDA has noted so many challenges that happened in the past years with clinical trials that investigators struggles with, sponsors struggles with, and in collaboration with the SNIH and other institutions, we have identified at least 10 that are in the field of clinical trials and have the infrastructure, but they're facing challenge. So we are all together as stakeholders are trying to resolve these issues. So that's honestly a really a big initiative. We have seen really successful stories so far, shortening the timelines, identifying those challenges, and mitigate the issue, these factors. Yeah. Thank you.
Thank you so much, Dr. Umayma. Dr. Abubakar, with your broad experience, mashallah, at NOBCO, at MOH, what the public-private partnership opportunities do you see for enabling data-driven ambulatory care models, and how can pharmacists lead these efforts from within the system? As we know, the public sector in terms of ambulatory care services is well advanced than, I'm not aware of any ambulatory care clinic that is existed or running in the private sector yet. So based on experience, what's your insight about that?
طيب السلام عليكم ورحمة الله وبركاته. صباح الخير جميعا. Good morning everyone. Thank you very much for this great question, but I would like to thank Dr. Mohammed Zaid and the organizing and scientific committees for this invitation and for specifying this kind of topic and discussion, which is really vital for the future advancement of ambulatory care practice in Saudi Arabia. When we talk about collaboration, regardless if it's public and private sectors, semi-governmental, pharmaceutical industry, that means there need to be a mutual benefit between the two parties. My experience at MOH is different than in the pharmaceutical industry, and now currently in the semi-governmental institutions where the business is the core focus of our operations. At MOH, any kind of collaboration between frontliners, healthcare professionals, or practicing practitioners, in light of the collaboration, comes with a focus, mainly to improve the outcomes of the patient, mainly to provide evidence, real-world evidence of such products, medical devices, and facilitate the access of these kind of innovations and medications or high-cost medications to land for these patients who need such patients. Another side of collaboration, from my experience at least with the pharmaceutical industries, that collaboration shifts in focus from actually providing evidence into facilitating access and empower the pharmaceutical companies to negotiate with, for example, SFDA, to register their new indications or new products and so on. يمكن الhuge opportunity اللي I just recently discovered, it was underscored and undermined and under-discovered, to be honest, and it needs a lot of attention. And there is a huge opportunity for all the pharmacists in Saudi Arabia to participate in, is the collaboration between the semi-governmental bodies and the authorities and the practitioners themselves, which I believe supports a lot, not only for the pharmaceutical industry, not for the practitioners, but for the sole purpose of why we wake up every day and go to work, our patients, and optimal patient care. The type of collaboration between semi-governmental and public or private institutions usually is focused on health economics, to make the high-scale decisions are much more better informed and مستندة يعني على evidence from population-specific data. I believe there is a huge opportunity in this, especially for those who goes to further step ahead and take further certifications in economics, pharmacoeconomics, health technology assessment, where these collaborations are still there. The opportunity is still there, but the missing part is the right qualification for those who would like to be involved in such research.
Thank you so much, Dr. Bakr. Dr. Bashir, if you allow me to call you the founding cohort of the ambulatory care residency program in Saudi Arabia, you and Dr. Abdulaziz. You experienced being the first resident in the M-Care, the first M-Care program in Saudi Arabia. What tools that you have observed back then and now as the RTPD for the AMCARE program, what tools that you have seen that augmented and empower clinical pharmacists, whether in the practice site or in your practice site or somewhere else?
Thank you, Dr. Abdallah, for your insightful question. And first, I'd like to thank the organizing committee and the scientific committee for working on such a conference that we are, of course, proud of. As an RBD, as a residency program director and a clinician too, I'd say that the characteristics of the clinical pharmacist or the practitioner, even as a resident, would impact their work, and of course would impact their treated community. Those skills, it's not only all about medications, it goes beyond the medication therapy management. It's about the management, it's about the interdisciplinary collaboration. Of course, as an AMCARE pharmacist, you get to deal with every single healthcare provider and even non-healthcare providers. And also, of course, comes first the patient. Also, other skills that helps in evolving the strong clinical pharmacist in AMCARE specialty is having a thinking of system-based thinking that goes not only on the patient, but on the whole environment that we are treating the patient in addition to data literacy. We know that with the development, with the technology, with AI, the data helps a lot in the future, helps in understanding the current situation and predicting the future of the management. So being able to collect those important data, understanding them, and making meaningful projects to help in the future is, of course, an important skill that you should learn or gain in order to come up with a bright future. Of course, an AMCARE pharmacist with no communication is not an AMCARE pharmacist. So communication on different levels is an important skill that should be existing and should be developed continuously. The communication goes to patient with the clinical practitioner and, of course, non-clinical stakeholders too, where you need to translate all your important data to them to make a meaningful and insightful information to help them making decision for future and for improving the health policies in the future of clinical pharmacists in general and specifically for AMCARE, and to be creative and innovative in your field. And of course, when we say innovative, it's not only by coming up with new ideas, but developing the existing ones to make a sustainable and scalable measurements. Yes.
Thank you so much. I know that there could be too many questions that I haven't asked and could have irritated some of the audience. Why don't you ask this question? So I'm not gonna, we're gonna allow maybe 15 to 20 minutes for the audience question. The last question, and please, I would like everybody to really participate. Dr. Mishal today have mentioned really a beautiful thing that really triggered me, that such conferences, it's really important in itself to empower ambulatory care pharmacy, especially at this era in time in healthcare transformation in Saudi Arabia, health clusters, the شركة الصحة القابضة. So really, we need to introduce the AMCARE through these conferences, through these talks, through our publications, innovations, startups. But to be specific in the questions, now we are heading toward privatization. We see that private sector, private hospitals is really getting governmental contracts. What kind of, and please, Dr. Sandra and Dr. Ibrahim, if you also can join us in answering this question, if you have any insights, how we could really convince negotiate with the private sectors, what the added value that can bring to the table to the private sectors, who really their mindset is at the end of the day is profit driven, you know. So how could we really empower care services in the private sectors, knowing that their mindset? And please, it's open for the entire panel.
If you allow me, Dr.
Yeah, please.
Thank you very much. This is a great question, صراحة. I know I left the practice يمكن a year ago, the clinical practice, but I'm still an ambulatory care clinical pharmacist, and I advocate for the ambulatory care clinical pharmacy. As I said, as Dr. Majid said, the future of clinical pharmacy lies on the hands of ambulatory care clinical pharmacists. When we talk about adopting ambulatory care model or clinical model in private sectors are usually data-driven, profit-generating, model of healthcare. And so I think the biggest responsibility lies on our fellows currently practicing to generate more of these data and to show the actual value and the tangible value of establishing such services, and how can they participate not only in optimal patient care, but also on the long run, how they save money by reducing complications, by providing such service, either counseling, anticoagulation, diabetes, and all these kind of different ambulatory care settings. And I welcome everyone of my colleagues to participate as well too.
Okay, I might echo Dr. Abu Bakr here, but focusing more that the pharmacist can generate money, save patients, and show these in numbers to the administration of the sector, whether it's private or public. The second thing that comes to my mind, you have to do research again to show that your setting is, or your clinic is really doing that benefit that is intended initially. The third thing that always comes to my mind, sustainability. You have to make sure that you train more people to take over whenever you want to establish bigger place or leave and have the clinic continuing in this area. You want to make sure also to have surveys to the patients, whether it's satisfaction type of surveys. You want to make sure also to collect data from your staff. Know that there are some metrics, qualitative metrics or quantitative metrics. Keep these in mind. This is like the short advice that I want to say that covers a lot of things that convince institutions in general and pharma industry. I don't know. It depends on the setting itself.
Of course, I would totally agree with the doctors, what the doctor said. And I'd like to share from my humble experience in the volunteering with King Salman Relief Center that even taking your skills outside the environment you raised in to different countries makes it a great opportunity for you to experience those skills and to add on. There is a great research opportunity comes from volunteering experience. There is a lot of innovative and low-cost intervention that happens there, and of course a lot of them are adaptable, and you can bring them home to the country to have a great low-cost and innovative solutions for a lot of our problems. In addition to changing your mindset that your research project or your innovation is not always something that has high resources or high tech. It can be a lot of things, but it should have a high empathy and high passion to produce a product that is effective and sustainable to the community.
I can really relate to what you have mentioned. I've been in Cameroon twice with the King Salman Humanitarian Aid Center, and I came across a patient that I was so negligent and telling the mother of the baby to keep the antibiotic in the fridge, the syrup. and the translator told me there is no electricity in their city. So I can really relate to it. What Dr. Bashar is really saying, that really working in, going out there, working in underserved areas, it can really trigger these skills, this analytical mindset to utilize the current resources efficiently. I myself really learned this from volunteering experiences, that whenever I go out there and come back, and I look at the resources available for me at a different perspective. How can I use it more efficiently? We are not really using our current resources efficient, and we are really lucky, honestly, alhamdulillah, at this era in time, with this support from the government, from the leaders, the legislators, and everybody really working for the well-being of Saudi citizens and the residents in Saudi Arabia. Please, I mean, if there is any point that I haven't tackled, Dr. Majid, Dr. Sandra, let me know. And I would like to shift to the audience. Please, if you can provide the mics, الميكروفونات. If you have any question, please.
Assalamu alaikum. Thank you for the panelists for this great discussion. I have a question regarding to the last question that you asked, if you allow me to elaborate. Convincing the private sector to have care clinical pharmacists, for sure, starts from how much they will get out of that service in terms of money or reducing the cost. So having the clinic like in a pilot phase in a service that they lack, which is like usually medication-related issues, adherence, complications, side effects, and you provide that service that many of other clinicians cannot do, it will, by time, convince them to have, for sure, an expert in the medication. And then after that, for sure, any pharmacists will participate. They will either generate money or reduce costs eventually, and you can support that as well by research. This is for the question. If you allow me to ask the panelists, I have a question for Dr. Sandra regarding the standard of care that she elaborated on. It's a unique thing to move from just asking for your privilege to like establish a standard of care and then ask the pharmacists in the country to be qualified at certain levels to provide specific services. Actually, two questions in that regard. The first is, who verifies the qualification of pharmacists to be able either to diagnose or to prescribe or not to do? This is the first question. Second thing, in order for pharmacists to be part of this transformation, do you have like specific after PharmD degree pharmacists can get, and like workshops, courses, or certifications they have to have before they can provide any diagnosis services or any prescribing privilege acquisition? Dr. Sandra, did you hear me?
Dr. Sandra, do you hear us?
Can you hear me?
Yes, we can.
Okay. So in the standard of care models, and we have about 5 states now that are moving in that direction, with more states looking at that progress and how we're defining the care of pharmacy or the practice of pharmacy. The first question you asked is who defines the standard of care? And it's actually, that's one of the areas we're looking at. Like in Idaho, for example, we're working with boards of pharmacy to be able to really be clear about what that standard is. And then also to the point that you're making around what are the areas of trainings or certifications. So when you're looking at pharmacists in different practice areas, their practice and the standard for a pharmacist within that area is going to be defined differently based on where they're practicing. And that will also define the level of scope, authority, prescribing ability that they have based on what they're doing. So I will give you an example. And I'm also equating that to what the medical profession does. When you have a surgeon or a cardiologist, they have different training to allow them to provide the care for that area that they've been trained in, and that allows them to practice in that area. You would not expect a family practice doctor to do the same as a cardiologist, right? That is a different standard of care for each of these two types of providers. Same thing for pharmacists. When we're looking at the standard of care for pharmacists, it'll be pharmacists that are in community, pharmacists that are in an ambulatory care setting, pharmacists that might be in a health system. They will be held to the standard based on that practice and compared to that practice type and those providers within that practice type. So the way that they're looking at that in, say, Idaho, they are requiring the pharmacist to maintain the education, the continuing education, the certifications that they would require for you to justify your practice within that type of care that you're delivering. So not just anybody can do it. You have to be able to be competent to do it. But the good thing is, and I think this is what I appreciate, because this happened in the United States and it's very frustrating. We have a collaborative practice agreement. And if you end up doing something in diabetes or hypertension or immunization, then they're regulating what CEs you need, how many hours, how much training for every single condition on top of what you've already been trained to do. So we're going to end up with 40 certifications, and then you have to maintain them. And the burden of just trying to do your job becomes your job instead of doing your job. So by doing more of a standard of care model, you're actually allowing the pharmacist to focus on the training that they've had and maintain that standard to maintain that practice versus focusing on all the regulation required for you to do your job. And it gets to the point where you can't sustain it with over-regulation. How do we actually remove that over-regulation and allow the pharmacists to practice the way they've been trained? It's very progressive. I mean, we've moved away from being afraid to say diagnosis, being afraid to say prescribing. There's a lot of scope issues here. The American Medical Association is not comfortable with that, not just for pharmacists, but for other professionals. But what we're seeing is a need. Patients need this. We do not have enough patients. Somebody mentioned medically underserved populations, rural populations, an aging population, and we do not have enough providers of any kind to manage all of the chronic conditions we're seeing. I was just at the scientific conference for the American Diabetes Association this past weekend. We only have, just to give you an example, in the United States, 7,500 endocrinologists in the entire country for 40 million people with diabetes and 100 million people with prediabetes. There is no way that the medical profession by itself will be able to overcome the challenge of managing these patients without the help of other providers. And that will take the help of pharmacists, nurse practitioners, physician associates. It's not just, one profession, it's all of us together.
Thank you so much.
Is there another question from the audience? Or a point that would like to be raised by one of the panel members?
Yes, Doctor.
Dr. Agada is...
You put me on the spot.
You have the mic, please, if you can share your insight about that.
Assalamu alaikum jami'an. Good morning. Nice to see you, Sandra, and nice to see you, Dr. Ibrahim. I think what you talked about regarding the standard of care for pharmacists, it really touches the scope of practice for pharmacists from the beginning. So if we set this up from the beginning, it will be easier for us to implement all of the activities that we are now aspiring to achieve. And I think one of the major obstacles in regard to the ambulatory care services and the advancement of the clinical pharmacist or the pharmacist patient care, direct patient connectivity, is the legislation part. And if that's solved, definitely all the other activities that's already done now in a shy way, in a very limited way, in very sporadic way, it will really become the standard of care that we're looking for. So if from this conference, if we really come up with a statement, an emphasizing statement that the regulation has to change the scope of practice of pharmacists, and if we adapted this, modified this standard of care approach that's been done in the United States also, that will help us to move forward to the next phase of not to prove ourselves, not to try to fight for our own, let's say, our own and rightful rights in practice, but it's going to be something for the next generation. It's going to be, that's the normal standard of care, standard of practice for pharmacists. So thank you, Dr. Sandra, for bringing up the standard of care, and I hope this conference will emphasize on this and transform it in a Saudi way to actually match our setting here in Saudi Arabia. Thank you all for your participation. Thank you. Thank you for Dr. Abdullah for putting me on the spot.
Welcome, Dr. Ghada. Dr. Majid, please.
Dr. Ghada, you should be always on the spot. But mashallah, yani, you always you are ready. My comment here, just to bring you back to the theme of the session, not to forget about research. يعني أعتقد مهم جدا that we emphasize on the importance of research and providing evidence. What I want to say as a final maybe comment, and it could be in the recommendation, is having, just to reiterate and emphasize on the importance of forming a team in the AMCare for research. Just to tell you the importance of this in the country, the whole national initiative for research. In the past, no one is taking care or leading the health research. Now, Saudi NIH leading the health research in the country, which means putting the many initiatives, in fact, to promote research. So be from among the frontiers for being lead researchers in the AMCare, and not only at a pharmacy level, but also the AMCare level, which is, again, the global level. This is one. Second, we have also launched the Relink. I'm sure some of you have heard of this in the Saudi NIH. So Relink is actually is a platform for researchers to group and gather around interest. So anyone from all specialties, not only for pharmacy, but also other medical specialties, would like to be involved in a research project for the national level. This is going to be a good opportunity for you. So what you need to do is to go to Relink, register, and then put your emphasis or research areas, and then you gather also a team around this. The third thing is take advantage of the research grants that we are announcing, which is going to be on Tuesday, 1st of July. There will be a grant announcement. It's open for everyone. It's not only limited to a certain specialty, but everyone. So take advantage of this. Try to, again, put your efforts to write a proposal for AMCare. I will definitely support you on this. Thank you.
Okay, you really triggered this question. I know it has nothing to do with the AMCare, but really extracting the data. Okay. If you allow me, like the organizers, to ask this question, it's really what's the role of NIH clinical trial in a safe day, Dr. Umayma, if you can share us, really to facilitate the access to this data, extract it, make it repeatable. One of the biggest struggle in AMCare or in other specialty is really to utilize the current data that we have. Different hospitals, different algorithms to extract the data. Sometimes, even now, with I guess like one system, if I'm allowed to mention the brand name, that really can extract in a press a button all the variables the researcher needs. But 99% of the health electronic systems, no, you need to go there patient by patient. And I talk about research, not clinical trial.
If you allow me, since the mic is with me. This is a very important question, Dr. Abdullah, and thank you very much. I know the time is, we overpass the time, but it is really important, and we realize the importance of this at Saudi NIH, of the many challenges, governing rules for the access of data, having different database in different institutions. So we are putting some efforts, in fact, to have governance rules for the data and make it available for researchers. The Saudi Health Council, they are the owner of most of the registries in the country, and they are willing and allowing people to have access, provided that there is rules and regulations in place. So this is one. Second is we are trying to reach out to the database owners in different institutions and group them in, or gather them in one platform. So we are going to maximize the access to the data. But this is really important, to have somebody who's taking the lead on at least regulating the access of to database that exist. يعني there are, so we have so many things عندنا في البايو بانك مثلا. There are huge data, hundreds of thousands of data available, but no one has access to it. Some of the institutions, they are willing to give access, provided that there is policy in place. So again, this is something ongoing now, and hopefully, inshallah, in the future, is going to be يعني accessible.
Okay, you want to elaborate? Okay, Dr. Majid, maybe the main reason that nobody is accessing or requesting to have an access to this data is the hustle of getting these IRBs in every hospitals, and every hospitals have different objective, different subjectivity sometimes, different rules. It's really exhausting and overwhelming, really, to pass this IRB ethics committee. Not to mention, I've wrote an article in Sub about the hustle and how the royal order that one ethical committee is sufficient for the researcher or the researcher teams to conduct their research and extract the data from different centers without having to go through a different IRB in different centers. What's your insight about this?
This is the dream, صراحة, to have this happening. I'm not sure, صراحة, even in the States, in Europe, the same thing. It's really has it, because it's accessing data. There is طبعا confidentiality. There is some restriction to the data itself and sensitivity of data. So I don't think hospitals or institutions willing to give full access to the data. يعني هذا, I think this is very clear to everyone. However, if we de-identify or maybe make it anonymous data, probably might give access with limited access. What we need is not the detailed information. It's only the information that we need to conduct and to maybe answer the questions, the research questions in mind, or maybe design a research utilizing the data. I don't think we have a solution for this. Many reasons. One is unifying the EMR systems in different hospitals. Nafis hopefully can solve this problem and is going to, inshallah, hopefully solve the problem. Having the Saudi Health Council is again trying to pull all registries, disease registries, and put it under their umbrella. This is another maybe way of unifying the efforts and the system. But again, it is a big challenge. It's in the mind of the decision makers, and hopefully, inshallah, we see a solution to this problem.
I hope that could be one of the recommendations for the conference, is really putting, I myself get benefit of, alhamdulillah, hundreds of thousands of grant funds, and I spend most of it on data collectors and data retrievers, really facing this hustle of sending my students, my master students, to the hospitals to get this data. Sometimes I really compensate them for the time, for the gas, for the transportation, and sometimes I ended up adding too many of my colleagues to the research projects to facilitate this data retrieval. And I think NIH Clinical Trials Saudi FDA, if could really put some of these funds to establish a platform really to facilitate the EMR system. Nafis, I think this is one that could utilize this funding and research more efficiently. And we could really, I always call the hospital data as, I'm not sure how to say this in English, الذهب الخام, that only needs some refining, and it's really gold. It's really gold that could contribute not only to publications, but really evidence-based medicine that generated from Saudi Arabia. And this is the passion, not only for ambulatory care pharmacists, but to every healthcare provider in Saudi Arabia. And this is what mashallah, Dr. Ibrahim has really mentioned initially, that we are the leaders. Really, I mean, data, if you have the data, if you can contribute to you cannot lead without really contributing to the international literature and platform. There is a question over there, please. If you allow me, Abdulaziz, she's before you.
Assalamu alaikum. Thank you for giving us these opportunities. My name is Wifaq Arabi. I am a clinical pharmacist. I have a master in the clinical pharmacy, and I am PhD student. Just my question is that if the Ministry of Health or the decision maker give us or give the clinical pharmacist to diagnosis or even to prescribe the prescription. If this allow for all the pharmacists, clinical pharmacists, to prescribe a prescription, or just there is a special characteristic for that pharmacist, like special courses or special or advanced certificate, just I want to ask. And the other part of my questions, if this is allowed just for Sweden or for the foreigner pharmacist. Thank you very much.
Regarding your point, Dr. Abdulaziz I think that point was really discussed thoroughly yesterday. I'm not sure if you were with us yesterday, but Dr. Abdulaziz, correct me if I'm wrong. I'm quoting Dr. Abdulaziz Al-Hassan. We are not dying to prescribe. There is a lot of liability and responsibility with prescribing, I mean. So we're not really eager to prescribe as is, but we are eager to make our services at the ambulatory care clinics more efficient. So it's meaningless that I come sit with the patient and I cannot really decrease the insulin couple of units down or couple of units up. And yesterday our colleagues discussed this thoroughly, that it requires a higher level modification and update to the rules and regulations. This is the part of your question regarding the prescribing authority for the pharmacist. And regarding the second part,
لو بس يعني طيب بس yesterday Dr. Mishal mentioned إنه there is a challenge في prescribing privilege للclinical pharmacists regardless of the level of education, whether it's PhD, whether it's a consultant level, PGY2, and currently the current practice for those who had this privilege, it's mainly institutional privilege. It was given by institution, not legislative. وكان التحدي اللي يمكن طرح البارح إنه إحنا in the process of transformation من Ministry of Health إلى الصحة القابضة. This is the biggest threat إنه الصحة القابضة, if it's going to run as a business model, it's going to say, why are you prescribing? ما في أي تشريع يعني يعطيك الحقية إنك تصرف, وبالتالي I, as a business, I'm not going to hold this liability. I give you this kind of privilege. Hopefully, inshallah, this conference will advocate for such privilege under certain criteria. Dr. Muhammad Zaid, inshallah, and the organizing committee as يعني مخرجات المؤتمر إن شاء الله بإذن الله.
Are you answering her question?
No.
Okay, just want because she has another part of her question. So as Dr. Abubakar mentioned, once the issue of this privilege, okay, currently, as Dr. Abubakar and our colleagues mentioned yesterday, it's in a hospital level. It's not on a ministry level or on a governmental level. That's the first point. And regarding the second point, whether the Saudi or non-Saudi, as long as you are licensed in Saudi Arabia, there is no distinction whatsoever in terms of nationality or in terms. It's just the qualifications and the licensure that was provided by the Saudi Commission for Health Specialties. Dr. Abdulaziz has a question.
عذرا بس بعطي أنا آسف آخر مرة. يمكن I'm gonna give you my experience. يعني when I got the prescribing privilege في King Saud Medical City وشفت level of responsibility وال liability اللي I can put myself in, رحت يمكن الدكتور أحمد الجديع قلت له أعطوني تأمين ضد الأخطاء الطبية. فهي لافت إنه أنت ناقين علينا أعطوني prescribing privilege بعدين تقول لي لا تعالوا حموني. فإتس responsibility و liability. بعدين سبحان الله بعدها بشهرين نزل التأمين الإلزامي ضد الأخطاء الطبية. فهذه يمكن
Is telling me so. Last question, please.
It is not a question, rather than it is a comment to finalize this session. I would like to thank all of you for being with us today in this conference. And thank you, Dr. Majid, for giving this great initiatives and great support to the community of AmCare. I believe and agree with you, all of you, no one can grow up without a community. Since we started this community as AmCare Pharmacy Specialty Network in 2020, I can remember it started this community by the chair, Dr. Abdullah Al-Hayfani, then moved to the chair of Dr. Umayma Arab, then moved to me lastly as a last elected board. We started many initiatives. We start from the 0 point, and we can say today we are reached to the break-even point that we can grow and collect all these efforts and bring all expertise and also support us from many institutions. يعني ما شاء الله تبارك in our today panel discussion in university, Saudi NIH, Saudi FDA, NIBCO, and also many of our colleagues in AmCare in many initiatives or in institution, we can bring all these efforts and resources and tools, and we can move ahead in AmCare. I believe AmCare in upcoming we be optimistic in very short time. And we have the privilege of prescription, we have the privilege of reimbursement model, and we have many supporting things in near future. Thank you, all of you. Thank you for everyone who supports us and bring all this initiative. And we will contact you, Dr. Majid, as a community of AmCare PSN to link with the Saudi NIH this initiative, because many effort done in personal level or in their own resources, either from university, either from us as a from field perspective. But we need someone from this institution with the biggest database, the biggest of international fund, in addition to that fund, to support us to move ahead in this part. This is what I have to say, and thank you for everyone and for our organizing committee.
Please join me to extend our deepest gratitude and thanks for our experts, the panelists. Thank you so much, and for really our restricted audience. Thank you so much. Assalamu alaikum.
Thank you, Dr. Abdullah, for this informative session. Now we'd like to ask Dr. Muhammad to come to the stage. We'll start with Dr. Abdullah Al-Hayfani, and also would like to thank our panelists online. Inshallah, next time they will be able to join us. Next, Dr. Majid Al-Juraisi. Next, Dr. Umayma Arab. Next will be Dr. Dr. Abu Bakr. Next will be Dr. Bashir. I'd like to thank also Dr. Ibrahim Sales and Dr. Sandra who joined us online, and inshallah they will be next time able to attend physically. Thank you very much. Now we'll break for 10 minutes, coffee break to get some fresh air. Then we'll come back to continue our scientific activity. Thank you very much. check. Check, check.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's my great honor to welcome you to the second session titled Expanding Access and Efficiency Telemedicine in Ambulatory Care Pharmacy. Our first speaker is someone whose career exemplifies both leadership and innovation in pharmacy practice. Allow me to introduce Dr. Faleh Al-Shahrani, a respected figure in pharmaceutical care and one of the pioneers in advancing virtual services in the kingdom. Dr. Faleh is graduated from King Saud University, where he earned both a Bachelor of Pharmacy and later on in pharmacy master's degree in hospital administration. He brings with him nearly 3 decades of diverse leadership experience across some of the most prestigious healthcare institutions in the kingdom. From his time at King Faisal Specialist Hospital and Research Center, to serve as a COE at Al-Jur'a Pharmacy Group, and to leading the pharmacy operations at Prince Mohammed bin Abdul Aziz Hospital in Riyadh. And now he's working at Sihha Virtual Hospital as a pharmacy path commander. His contribution extended well beyond clinical practice. He has earned multiple national recognitions in medication safety, quality, and management. He has played an active role in committees in Ministry of Health, Saudi FDA, and in the broader health transformation journey. Today, Dr. Faleh will speak on timely and vital topic titled Telemedicine Clinic and Remote Patient Monitoring, Improving Medication Adherence and Outcome. Please join me in welcoming visionary leader and dedicated healthcare innovator, Dr. Faleh. Stage is yours.
السلام عليكم ورحمة الله وبركاته. يطيب لي أن أشكر تجمع حائل الصحي ودكتور محمد الزايد واللجنة المنظمة وكل من استقبلنا وأكرمنا في منطقة حائل. شكرا جزيلا لكم. We're going to talk about can you change the presentation? Who is responsible here? ولا ما له دخل هذا؟ طيب. We're going to talk about telemedicine clinic, remote patient monitoring, improving medication adherence and outcomes. RBM is the use of technology, digital technology, to transfer patient data from home or distance area to the healthcare professionals in the hospitals, and this will gonna to improve patient medication adherence. In USA, they found the cost of non-adherence around 300 billion per year, and 100 billion attributed to avoidable hospitalization. Reason for non-adherence. The first one will be patient-related factors. Memory issue, and this is related to many regimens of medications, dementia or busy schedule, and this is we're going to use the technology to improve the memory issues. Lack of understanding the patient need to know why and when, and the side effect and food and drug interactions to be aware. Beliefs about medications, lack of necessity. If the patient, or most of the patient, or the chronic patient, they don't have symptoms, and they don't know the value of the medications. So, as a pharmacist, we have to explain these points. Fear of side effects.